Assalamu alaikum. Today we will talk about rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disease. Not only affects joints, but also affects other organs like skin, eyes, heart, and lung. The commonly affected joints are hands and feet, but it can affect any joint lined by synovial membrane. The pathogenesis of rheumatoid arthritis is still unclear, but it is theorized that an autoimmune reaction is triggered by interaction of certain factors. These factors are genetic factors, as rheumatoid arthritis is linked to HALA-DR1 and HALA-DR4, smoking cigarettes, infection like Epstein-Barr virus, mycoplasma, or Porphyromonas gingivalis, which cause gingivitis. The synovial fluid of the patients with rheumatoid arthritis found to have high levels of antibodies to these bacteria. Trauma to the synovial membrane and sex hormones, as evidenced by why rheumatoid arthritis is commoner in females and why its remission during pregnancy and recurrence during postpartum period, and also why reducing numbers in women taking oral contraceptive pills. These factors interact, leading to modification of our own antigens like type 2 collagen and vimentin. Vimentin is an intermediate filament protein in cytoplasm, has a role in cell support. Type 2 collagen and vimentin got modified through a process called citrullination, in which the amino acid arginine is converted to citrulline, and the immune cells recognize it as a self-antigen, causing macrophages in the synovial fluid to release cytokines like interleukin-1, 6, 8, and tumor necrosis factor alpha. These cytokines stimulate proliferation of fibroblasts in the synovial membrane, leading to synovial hyperplasia and hypertrophy, forming what is called pannus. This pannus leading to subsequent destruction of the surrounding organs like cartilage, tendon, ligaments, bone, and blood vessels. Again, these fibroblasts secrete proteases, leading to more destruction of the cartilage. And the interesting here that these fibroblasts can migrate from joint to joint through blood vessels, and that may explain the symmetry of rheumatoid arthritis. Stimulation of CD4 T helper cells in the synovium, causing release of more cytokines like interleukin-2, 17, interferon gamma, leading to more stimulation of macrophages, fibroblasts, and also stimulate osteoclasts, causing bone erosions. Finally, stimulation of B cells produces cytokines and autoantibodies like rheumatoid factor and anticyclic citrulinated peptide or anti-CCP. Presentation of rheumatoid arthritis. The typical acute presentation is persistent symmetrical polyarthritis that affects metacarbophalangeal and proximal interphalangeal joints of the hands and metatarsophalangeal joints of the feet. The patients present with symmetrical swollen, painful, stiff, small joints with limitation of movement, which was at morning and relieved with active exercise. Also, atrophy of interosseous muscles is a typical early finding. In some patients, rheumatoid arthritis has an insidious onset, which means gradual and tricky, as it may begin with constitutional symptoms only, like fatigue, low-grade fever, weight loss, arthralgia, before the appearance of overt joint inflammation and swelling. If the patient left untreated, spontaneous remission is uncommon, especially after the first 3 to 6 months. Later, the rheumatoid arthritis becomes chronic, results in joint destruction and deformities. If we examine the upper limb, we can find many deformities in the fingers and hands. For example, swan neck deformity, which is hyperextension at proximal interphalangeal joint with flexion at distal interphalangeal joints. Boutonniere deformity, which is flexion at proximal interphalangeal joint with hyperextension at distal interphalangeal joint. Z deformity of the thumb, which is hyperextension at interphalangeal joint with flexion at metacarbophalangeal joint. Ulnar deviation, due to loss of metacarpophalangeal joint stability due to weak ligaments and tendons insertion at metacarpophalangeal joints. Dorsal subluxation of the ulna. The ulnar styloid process becomes protruding when arm in full pronation gives the appearance of piano key sign. The positive piano key sign means when you press on ulnar styloid process, it becomes painful and it returns back into position like a piano key. And this may lead to rupture of extensor tendons of fourth and fifth fingers. Also, we can find entrapment neuropathy, which may result from flexor tenosynovitis or inflammation of the tendon and its sheaths, which make a pressure on these nerves. We have two examples for entrapment neuropathy. First, entrapment of the median nerve or carpal tunnel syndrome, which causing decreased sensation on the palmar aspect of the thumb, index, middle and radial side of fourth finger, with wasting of thinner muscles. Also, entrapment of ulnar nerve, which causing decreased sensation of little finger and ulnar aspect of the fourth finger, with wasting of hypothenar muscles. Rheumatoid arthritis can affect cervical spine. The atlantoaxial joint is a synovial line joint, so it is susceptible to the same pathology seen in peripheral joints. The patient is usually presented with neck pain, stiffness or movement with occipital headache. Tenosynovitis can occur to the transverse ligament of C1, may lead to C1-C2 or atlantoaxial joint instability, with subsequent cervical subluxation and serious neurologic manifestations. The neurologic manifestations like radiculopathy, which is the most common due to nerve root compression at C2, spinal cord lesions like quadriparesis, and transverse ischemic attack and cerebellar signs due to vertebral artery or basilar artery impingement. Extra-articular manifestations and complications of rheumatoid arthritis. Rheumatoid arthritis is a systemic disease. Not only affects joint, but it can affect several organ systems. Number one, rheumatoid nodules, which are commonly found on extensor surfaces and sites of pressure points, like olecranon process, proximal ulna, and the back of the heel, and can be found on subcutaneous tissues of fingers. Rheumatoid arthritis can cause vasculitic lesions, which are palpable purpura or skin ulcerations. It can affect the heart, increasing the risk of coronary ischemic heart disease due to inflammatory cytokines which cause endothelial cells dysfunction and so accelerate atherosclerosis and atheroma formation. It can cause pericarditis and pericardial effusion. Rheumatoid arthritis affects the lung, causing interstitial lung fibrosis, which also can be induced by methotrexate, and it is difficult to distinguish from that naturally occurs as a complication due to rheumatoid arthritis. It can cause Kaplan syndrome or rheumatoid pneumoconiosis, which is a nodular lung condition occurring in dust-exposed persons having rheumatoid arthritis, like coal workers, asbestos, and silica workers. It can cause pleural effusion and bronchiectasis. Kidneys are not usually directly affected by rheumatoid arthritis, but can be secondary to medications like nonsteroidal gold and cyclosporine, amyloidosis, associated Sjogren syndrome, in which there is lymphocytic infiltrations of the salivary gland, parotids, and lacrimal glands, leading to dryness or Zika syndrome. Also, it affects kidneys producing tubulointerstitial nephritis. Rheumatoid arthritis can affect eyes, causing scleritis, which is inflammation of the sclera leading to ocular pain, and weakness of the sclera, causing condition called scleromalacia perforans. Also, it can cause episcleritis, which is inflammation of the episclera, the layer between the sclera and conjunctiva, causing painless red eye. Felty syndrome, which is a triad of rheumatoid arthritis, splenomegaly, and neutropenia with recurrent bacterial infections. You can find proximal myopathy, may be due to inflammatory myositis, motor neuropathy, or disuse atrophy due to joint deformities. Anemia. Anemia in rheumatoid arthritis has many causes. We will try to mention these causes. First can be normochromic normocytic anemia, or anemia of the chronic disease, as rheumatoid arthritis is a chronic inflammatory condition. Can be autoimmune hemolytic anemia or pernicious anemia, as rheumatoid arthritis is an autoimmune condition. Iron deficiency anemia due to gastrointestinal blood loss from using non-steroidal, or Felty syndrome due to hypersplenism. Can be due to folate deficiency from using methotrexate, or bone marrow suppression due to some medications used in rheumatoid arthritis like methotrexate, sulfasalazine, penicillamine, and gold. And can be also due to chronic kidney disease. Finally, rheumatoid arthritis is associated with lymphoma and other cancers like colorectal cancers and stomach cancers. Diagnostic criteria for rheumatoid arthritis. It is a score-based system including 4 factors. These factors are joint involvement, serology, acute phase reactants, and duration of symptoms of synovitis. First, joint involvement, which consists of swelling and tenderness on examination, plus or minus presence of synovitis on imaging studies. If we find one large joint, for example, shoulder, elbow, knee, hips, or ankles, we give 0 points. If we find 2 to 10 large joints, we give 1 point. If 1 to 3 small joints, like metacarpophalangeal joint, proximal interphalangeal joint, or metatarsophalangeal joint and wrist, we give 2 points. If from 4 to 10 small joints, we give 3 points. And if more than 10 joints, at least one of them small joint, we give 5 points. Number 2, serology. At least one test result is needed. If negative rheumatoid factor and anti-CCP, we give 0 points. If low positive rheumatoid factor or anti-CCP, we give 2 points. And if high positive rheumatoid factor or anti-CCP, we give 3 points. Number 3, acute phase reactants. At least one test result is needed. If normal C-reactive protein and ESR, we give 0 point. And if abnormal CRP or ESR, we give 1 point. Number 4, duration of symptoms of synovitis. If less than 6 weeks, we give 0 point. And if equal or more than 6 weeks, we give 1 point. And so the diagnostic score will be equal or more than 6 points. Investigations for rheumatoid arthritis. The diagnosis of rheumatoid arthritis can be made by a combination of clinical, laboratory, and imaging criteria. The lab test can be done for rheumatoid arthritis are: number 1, rheumatoid factor, which is positive in up to 80% of patients with rheumatoid arthritis, but it is not specific for rheumatoid arthritis and can be found in other connective tissue diseases and autoimmune disorders. Number 2, anti-CCP, which is highly sensitive and specific for rheumatoid arthritis. Anti-nuclear antibodies can be present in 40% of patients with rheumatoid arthritis, and ESR and CRP, which are associated with disease activity, and also CRP values correlate with radiographic progression. The X-ray findings of rheumatoid arthritis. Number 1, we can find fusiform periarticular soft tissue swelling, which represents edema, joint effusion, and tenosynovitis, which is the inflammation of the tendon and its sheath. We can find joint space narrowing and erosions, but without osteophytes, not like osteoarthritis. And finally, juxta-articular osteoporosis, which may be due to disuse of the joints or can be due to corticosteroid therapy. Treatment of rheumatoid arthritis. The treatment of rheumatoid arthritis should be non-pharmacological, which depend on patient education, occupational therapy, and physiotherapy, and pharmacological, in which we can use non-steroidal. The non-steroidals can be used in a short course to reduce swelling and pain, but they don't prevent joint destruction and so are not sufficient to treat rheumatoid arthritis alone. Corticosteroids, which can be used in a short course at lowest dose until the response of 2 DMARDs is achieved. Number 3, DMARDs, which can be divided into non-biological and biological. Non-biological, like methotrexate, sulfasalazine, leflunomide, azathioprine, hydroxychloroquine, cyclosporine, and gold. And biological can be anti-TNF, for example, etanercept, infliximab, and adalimumab, and non-TNF, like interleukin-1 inhibitor, for example, anakinra, and B-cells deleting monoclonal antibodies like rituximab, which delete CD20 B cells. The main target in the treatment of rheumatoid arthritis is to achieve clinical remission. Patients should be started on DMARDs as early as possible, ideally within 3 months of starting symptoms. And methotrexate is the preferred first-line treatment unless contraindicated. In this case, we can use sulfasalazine or leflunomide. Patients with active arthritis should be monitored every 1 to 3 months, and this monitoring includes joint counts, tenderness, swelling, ESR-CRP, radiographic progression, and functional capacity assessment for the patient. If the treatment target is not achieved after 3 months with the first DMARD, in this case, a combination DMARDs or adding biological therapy should be considered. If the biologic DMARDs has failed, so we can use another biologic DMARDs with the same or different mechanism of action. If the patient is in persistent remission, we can consider tapering biologic DMARD, especially if this treatment is combined with non-biologic DMARD. And if the patient is still in persistent remission, we can also consider tapering of the non-biologic DMARD. Now be careful. Before starting pharmacological treatment with either non-biologic or biologic DMARDs, the patient should receive pneumococcal, hepatitis, influenza vaccines, and now they add herpes zoster and human papilloma virus vaccines. Now we will mention commonest side effects for the medications used in rheumatoid arthritis. Methotrexate, sulfasalazine, azathioprine, and leflunomide all can cause neutropenia, thrombocytopenia, and abnormal liver function tests, so need to check CBC and liver function tests every month. Methotrexate can cause interstitial pneumonitis and lung fibrosis, and leflunomide can cause hypertension, so need blood pressure monitoring. Hydroxychloroquine can cause corneal deposits and retinopathy, so baseline ophthalmology screening should be done before starting treatment, and yearly visual acuity monitoring is needed. Cyclosporine can cause renal impairment, hypertension, tremors, and gum hypertrophy. Gold can cause membranous glomerulonephritis, hypertension, proteinuria, and neutropenia, so need to check CBC and renal function test before each injection. The side effects of biological therapy. It increases the risk of TB or opportunistic infections. It is associated with T-cell lymphoma. It can worsen heart failure and cause hematological disorders like leukemia and pancytopenia, and can cause hypersensitivity reactions. What are the contraindications of biological treatment? We cannot use biological treatments in these cases. If the patient has latent or active TB, or any acute or chronic infection, or septic arthritis in the previous 12 months, or if the patient has demyelinating disease, and pregnancy or breastfeeding, congestive heart failure, and finally, if the patient has a history of recent malignancy. At the end, if we examine patients with rheumatoid arthritis, we should examine for deformities in the peripheral joints. We should examine the cervical spine for cervical subluxation, as it can cause serious neurological problems. We should examine for extra-articular manifestations like rheumatoid nodules, and search for complications like eye complications, interstitial lung fibrosis, and pericarditis. We should assess the disease activity like tenderness, swelling, and stiffness of the joints, and finally assess the functional capacity of the patients and to how extent he can use his joints. For example, we can let the patient to pick up a coin or button and unbutton his clothes. Thank you. Assalamu alaikum. Today we will talk about rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disease. Not only affects joints,